Hello, my name is Catherine Smith. I work as the lead pharmacist for cardiology at the Worcestershire Acute Hospitals Trust. So today I'm going to explain the reasoning behind some medication commonly used to help protect your heart. I'm going to outline the benefits of these medicines. I'm going to highlight the potential risks of these medicines, inform you of the best way to take your medication, and to discuss some of the interactions with your medicines. So the first group of drugs I'm going to talk about are the antiplatelet medicines, and these are things like aspirin, clopidogrel, prasugrel and ticagrelor. So why do we use them? So we use them to prevent the development of clots in patients that have narrowing of blood vessels and to prevent clots forming around stents placed in the blood vessels within your heart. So what do these do? So within your blood there are components called platelets, and these can clump together to form a clot. Clots are more likely to form when blood vessels are damaged or narrowed, like an angina, and antiplatelet medicines reduce the stickiness of these platelets to prevent them sticking together and forming clots. So the lowest effective dose is used to minimise side effects. You'll notice if you're on aspirin, you're only on a 75mg dose, because we know that dose as low as that still works as an antiplatelet, but won't have as many side effects. It's very important to keep taking these medications unless you've been specifically instructed not to, especially if you have a stent. So for example, if you need a dental procedure or a knee operation, you mustn't let anybody stop these medicines unless it's been discussed with a cardiologist. Clopidogrel, ticagrelor and prasugrel are normally used in combination with aspirin in specific conditions for a fixed period of time, and that's normally 1 year. Aspirin is usually a lifelong treatment. However, if you are taking an anticoagulant like warfarin or one of the newer anticoagulants like apixaban, dabigatran, rivaroxaban or edoxaban, you may not be taking aspirin at all, or you might be on another antiplatelet depending on your risks. So what are the side effects of antiplatelet medicines? So bleeding is an obvious side effect. These are medications that are going to reduce your risk of forming clots. So unfortunately, it does increase your risk of bruising more easily and bleeding more readily. Things like nosebleeds will be more common as well. Indigestion, you'll all know that aspirin can cause indigestion. Ticagrelor can give you a feeling of breathlessness. It's a recognised side effect which normally is self-limiting within the first few days, and we do have an idea of why it happens, and it's not really harmful, but if it's causing any problems we can switch you to an alternative. Some of the points to make, so like I say, take aspirin with or after food to help protect your stomach. And do inform your GP if you're suffering from new indigestion type pain, because as you'll know, sometimes it can be difficult to distinguish from cardiac chest pain. We'd just want to make sure there was nothing going on there. So the next group of drugs I'm going to talk about are statins. These are a group of drugs that all of you will have heard of, and probably most of you are on or have been on. They're incredibly widely prescribed throughout the world, and they include drugs like atorvastatin, simvastatin, pravastatin and rosuvastatin. So what they do is they reduce cholesterol by blocking a process in cholesterol production in the liver. They don't have any effect on your dietary cholesterol really, so it's still important to have a diet which is healthy and low in saturated fats. And what they do is they target what we call the LDL, or the bad cholesterol. Not so much the cholesterol itself, but how that cholesterol is excreted in the body so that it's not circulating around through your arteries and clogging them up. They also have another effect, which is that they stabilise atherosclerotic plaques in your coronary arteries, and that's where plaques can sit in your artery. If they rupture, a thrombus can actually form which can block off your artery, and that may well have been what's happened to some of you who are listening. And that effect is actually aside from their cholesterol lowering effect. So even if you have low cholesterol levels, it's still important to treat with a statin after a heart attack. They can reduce the risk of further cardiac events by 60%. Generally though, statins, any statin at any dose will reduce your cardiovascular risk, so they are important. And they do have this, like I say, this anti-inflammatory effect upon your coronary blood vessels, so it's not just about lowering your cholesterol. So why do we use them? So we use them in primary prevention, and this is in patients who haven't actually had a heart event, but they would be considered high risk. They would have more than 10% risk of developing cardiovascular disease within the next 10 years. In most of your cases, it'll be secondary prevention, so prevention of further heart disease in those who have confirmed coronary artery disease. And remember, cholesterol reduction is beneficial even if the cholesterol level is not high. Side effects of statins. So very occasionally people will experience things like headaches, nausea, vomiting, abdo pain, but by far the most commonly reported side effect is muscle pain. And it is usually a pain or tenderness in your arms or legs, or sometimes described as a cramp. And it's important to report unexplained muscle pain or tenderness or weakness to your GP, because it is something that we can check. They can take a blood test which will tell us whether there's been any muscle breakdown. They can stop the statin for a while, give you a statin holiday. If your condition improves, it probably was the statin. If it doesn't improve, it probably wasn't. But they can switch you to a different statin. They can change the dose, change the timing, and certainly do something to help. So it's not something you should be putting up with unnecessarily. Advice regarding alcohol is pretty much the same with all the medications I'm going to talk about. So we would just say drink within normal recommendations and avoid high alcohol intake. The reason I mentioned with statins is because the liver is involved in their metabolism. Target cholesterol levels. People always want to know what we should be aiming for, and it's really the lower the better. So with a total cholesterol less than 5, a non-HDL, which is the bad cholesterol of less than 4 at least, and an HDL, which is the good cholesterol, more than 1. We also look at triglycerides, which is another type of lipid associated with heart disease, and we'd like that to be less than 2. But like I say, in general, we just want cholesterol as low as we can get it. If there is at least a 40% reduction, that is really what we're aiming for. And again, remember, even if your cholesterol is normal, if you have coronary heart disease, statins are still beneficial to you and still have mortality benefits. Some other points to mention: simvastatin and pravastatin have to be taken at night time after your evening meal, and that coincides with your nocturnal cholesterol production. And the reason is that simvastatin and pravastatin are very short acting. Atorvastatin and rosuvastatin are very long acting, so they really can be taken at any time and they'll still be effective. Your GP should monitor your liver function, so our national recommendation is that your liver should be checked at 3 months and 12 months, and if it's normal then it doesn't need to be checked again. You should avoid large quantities of grapefruit juice, especially with simvastatin, and that's because it affects the metabolism of the drugs, so you'll end up with a higher circulating level in your blood, and that would put you at increased risk of side effects. But I would say that please don't panic if you accidentally have some grapefruit juice or you're worried that you might have had it in something. It's just that we wouldn't recommend you take it regularly at all if possible. And again, statins are used in combination with dietary interventions and they're not replacement. So unfortunately, if you're on a statin, it doesn't let you just eat whatever you like, unfortunately. So if you are somebody that doesn't get on well with statins, there are other lipid regulating drugs that we can use. The alternatives are, there's a drug called ezetimibe, which actually prevents the absorption of your dietary cholesterol. And although it works in a very different way to statins, it still has a similar side effect profile, so you can still get muscle pain with ezetimibe. The good thing about ezetimibe is that we can use it now in combination with statins. So if you don't tolerate a high dose statin, we always recommend 80 milligrams of a statin because that's the best evidence. So it's the drug with the best evidence at the dose with the best evidence. And if you can't tolerate a dose that high, you might be able to tolerate a low dose of atorvastatin in combination with ezetimibe. And there is some evidence that that does reduce your cardiovascular risk. Whereas ezetimibe on its own, although we know it reduces your cholesterol, similar to things like margarines and yogurts can reduce your cholesterol, there's no evidence that that will actually reduce your cardiovascular risk. There are other drugs like fibrates, which are very rarely used these days and not really recommended because they're not particularly effective, but they do also reduce cholesterol and triglycerides. And again, although they work very differently to statins, they do have a similar side effect profile and can still cause muscle pain. There are also some injectable cholesterol reducing medications available now called PCSK9 inhibitors, which are available for some patients who are high risk or who have very high cholesterol and who meet certain strict criteria, and they're injected by the patient themselves, usually once every 2 weeks, and they're incredibly effective at reducing cholesterol. But at the moment they're only available if you don't tolerate lots of statins and you have to have cholesterol levels within particular ranges. So beta blockers, another really commonly used group of drugs in cardiology. These are things like atenolol, bisoprolol, carvedilol, metoprolol and nebivolol. And what they do is they work by blocking hormones like adrenaline, and that reduces the workload upon the heart. They also reduce blood pressure and they prevent the heart from beating too quickly. So why do we use these? So one of the main reasons we use beta blockers is for angina. So by slowing your heart rate down, that actually improves the efficiency of your heart and reduces chest pain from angina. We use them to prevent future heart attacks. So if you've had a heart attack, you'll find that you'll have been given a beta blocker within your goodie bag of drugs to take home. We use them in heart failure. So these are drugs which will help to improve the function of your heart if there's been any damage to it. And we use them if you have an irregular heartbeat and arrhythmia, because they slow the heart rhythm down, and that can improve the efficiency and it can stop the heart being too stressed by a fast heart rate. They do have an effect on blood pressure, but it's not our primary reason for using beta blockers. And you may not be able to have them if you have peripheral vascular disease, which is a condition where you have poor circulation in your limbs and your extremities, and also in asthmatics. Some asthmatics find that beta blockers will increase their wheeziness. The side effects of beta blockers are in many ways related to their heart rate lowering effects. So by slowing your heart rate down, it can feel like your whole body's been slowed down and you feel fatigued. Normally that does improve over time, but it can take quite a while. Some patients have very, very cold hands and feet. And that goes in with what I said about them being a problem in patients with peripheral vascular disease. Some patients have nightmares or sleep disturbances, and this is quite easily remedied. We can always put you onto a different one that doesn't cause that problem. I've already mentioned the breathing difficulties in asthmatics. And bradycardia is when your heart is too slow, so that might be that you're on just too big a dose, or it might be that you don't tolerate beta blockers at all and we have to stop them, because a low heart rate, which is very, very low, will make you feel a bit grotty and a bit lightheaded and not very well at all. The same advice with regards to alcohol, so moderate amounts of alcohol is recommended. And these are another group of medications we would say to not run out of, because stopping beta blockers suddenly can cause an effect of chest pain. So especially if you're on it for angina and you stop it suddenly, it can cause chest pain. ACE inhibitors, so these are drugs like ramipril, enalapril, lisinopril and perindopril. What these do is they reduce your blood pressure very effectively and dilate your blood vessels. This reduces the workload of your heart and enables your heart to work more efficiently as a pump. So your heart is just a big piece of muscle and it's working as a pump. And if it's been damaged by a heart attack, for example, it might not work as effectively as it could do, and these medications will help it work better and function as a pump. They also promote the body to lose excess water and salt, so if you're holding on to fluid, it'll stop that from becoming a problem. So we use them often for high blood pressure, but we use them as well for heart failure. Similarly to the beta blockers, they will improve the function of your heart. They can also prevent remodeling of your heart tissue after a heart attack. So sometimes your heart will try to compensate becoming a bit bigger, but actually it can become a bit floppy and ineffective, and that can be stopped happening by ACE inhibitors. They can also prevent heart attacks happening again. So again, they're one of the medications we would give you after you've had a heart attack. And they do also minimise problems associated with diabetes, so they can protect your kidneys. Side effects are mainly related to the blood pressure lowering effects, so things like dizziness and weakness, hypotension, especially after the first doses, and on dose increases. So sometimes we would recommend you take them at night time because you may not be as affected by the low blood pressure as if you have them during the day. Some people have a bit of a loss of taste or appetite. They feel that things just don't taste the same as they normally do with ACE inhibitors. And the main side effects we hear about is a persistent dry cough. This normally improves after a few weeks, but it can be a bit irritating and it's not harmful. We know why it happens, and there is an alternative if you do find it's causing you problems. Driving, Just be a little bit careful because these drugs do lower your blood pressure, and just be aware of how they affect you before you drive. Alcohol-wise, be aware that they may increase the blood pressure lowering effects of alcohol. Routine blood monitoring will be carried out by your GP, and that's just to check kidney function and particularly potassium as well. We do recommend that you avoid salt substitutes that are high in potassium, like low salt, unless that's been discussed with your doctor, because potassium can be increased by this group of medications, especially if you have kidney problems already. So if you're one of the people who does have this dry, irritating cough, these are the group of drugs that can be used as an alternative. They're called angiotensin II receptor antagonists. And these are drugs like candesartan, irbesartan, losartan and valsartan. And like I said, they're often when patients cannot tolerate ACE inhibitors due to a cough. They have very, very similar actions on the body and side effects to ACE inhibitors, and the same routine blood monitoring is recommended. And you're probably wondering why we don't use these as our first line treatment, but it's just that we just don't have quite the same body of evidence as we do for ACE inhibitors, so that's why they're not first line treatment. So the next group of drugs are nitrates, and you probably all recognise the little spray on the picture. It's things like glycerol trinitrate or GTN, isosorbide mononitrate, isosorbide dinitrate. And what they do is they dilate blood vessels, so they act as vasodilators, improves the blood and the oxygen supply to the area of the heart where there may be a narrowing of the blood vessel, and therefore that reduces pain. So when your muscle is not getting the oxygen it needs, that's when you have chest pain. So we use nitrates to relieve or prevent expected chest pain. So for example, if you know that when you walk up a big hill it's going to cause you chest pain, maybe you might take the GTN spray before you start. It can be used to prevent regular chest pains, so in the form of nitrate tablets or patches for angina. And the side effects, most of you will be able to tell me the side effects if you've ever used this spray. So it's things like flushing, headache, dizziness, postural hypotension. That's when your blood pressure drops suddenly when you stand up. And these things are all due to the vasodilating effect nitrates, so they're opening up your blood vessels, not just to your heart, but also up to your head as well, which is why you get the headache. It's also worth pointing out the interactions with nitrates. So drugs like sildenafil, vardenafil and tadalafil, which are the Viagra type drugs, will cause a significant drop in blood pressure, so you mustn't use them together. Driving wise, it may cause dizziness, so be very careful after you've used your GTN spray. And alcohol wise, again, it can potentiate the effects of alcohol, so be very careful. Just some other points with nitrates. If you have the GTN tablets, which are the ones that you get in a little jar, and you can pop them under your tongue to use when you have chest pain, some people prefer them because they can spit them out as soon as the pain is resolved, but before the headache occurs. But just a point to mention is that they do have an 8-week expiry once you've opened them, so if you don't use them very often, you'll find that the next time you go back to them, they just won't work as well. You can buy GTN sprays over the counter in your pharmacy, so if you run out or you're away somewhere and you haven't got one, you can buy them, but just be aware that the pharmacist will probably ask you lots of questions and be very concerned about you because they might want to phone you an ambulance, but you might just have to kind of reassure them that this is something you normally have. If you're daily isosorbide mononitrate, take them in the morning and early afternoon, and that reduces the risk of tolerance. If you have a lot of nitrate in your system all the time, you will become tolerant to it. So by taking it morning and early afternoon, it gives you a bit of time when your body doesn't have so much of it in the system. There are some other anti-anginal drugs as well, just to mention. So things like nicorandil, another vasodilator with very similar side effects and interactions to nitrates. One of the things about nicorandil though is it can cause some nasty ulceration anywhere really in your GI tract, so that's just worth mentioning. Ivabradine, this is a drug that can reduce your heart rate, so it can be used as an alternative to beta blockers or in addition to them, but it's not suitable for patients with abnormal heart rhythms like atrial fibrillation. It just doesn't work in those patients. Side effects are obviously, again, a slow heart rate, and it can cause headache, dizziness and vision disturbance. Ranolazine is another vasodilator, a sort of on its own in class vasodilator. And there are calcium channel antagonists, which is a big group of drugs, including things like amlodipine, verapamil, diltiazem, lercanidipine, felodipine, and they reduce the heart contractility and dilate blood vessels, so they do increase the oxygen supply to your heart. Some of them can slow down your heart rate as well, so you can use them instead of beta blockers, but they can also cause headaches, flushing and dizziness, and that's because, again, they work like vasodilators do, so they're opening up the blood vessels to your head as well as everywhere else. And it's another group of drugs that do interact with grapefruit juice, but not to the same extent as statins. Drugs used in heart failure. So these are mainly things like diuretics, so water tablets is what we would call them, loop diuretics, furosemide and bumetanide, thiazide diuretics, bendroflumethiazide and metolazone, and also another one called indapamide, and then the potassium-sparing diuretics, spironolactone and diplerenone. So what do? Well, they act on the kidney to cause water loss, therefore lowering blood pressure and removing excess body water. Spironolactone and diplerenone are beneficial in relieving symptoms of heart failure as well, so they're actually a bit more clever than simply losing fluid. They also, like ACE inhibitors, prevent your heart becoming big and floppy, and they improve the function of your heart as well, so they do things a little bit more sophisticatedly than the simple diuretics. Side effects wise, so not unsurprisingly, increased frequency of urination, so we'd say take them in the morning. If you're on twice a day, probably take them morning and lunchtime so that it's not interfering with your sleep too much. Altered blood electrolytes, so when you're losing all this fluid, you're also losing electrolytes or salts as well, so it's important to have those checked to make sure you're not losing too much. And your GP will do that probably every 6 months. It depends on what your baseline kidney function is like. Some people find they upset their stomach a bit, so it can take a bit of time and trial and error to get you on the right combination. And this thing called postural hypertension again, so in dropping your blood pressure, you can find that when you stand up quickly, you'll feel dizzy, and it's just a case of really being aware of how it affects you and being careful when you're standing up. So the last section is about over-the-counter medicines. There's a wide perception that if it's off prescription, it's safe or safer. But there are some over-the-counter medicines that are harmful for people with heart disease or who are on heart medication. The best advice really is to check with your pharmacist before purchasing, preferably your own pharmacist who has access to your own medication history and knows what you normally take. So the first section is decongestants. So these are present in some cough, cold, flu and hay fever remedies, and there's a list of some of the ones you might be familiar with, but it's certainly not an exhaustive list. These can increase your heart rate, they can increase your blood pressure. Often they're full of sugar, so they can alter diabetic control, and they do oppose the actions of beta blockers. So we don't recommend that you take them, certainly for more than a few doses. If you've had them in the past, and I wouldn't panic about it, but I just wouldn't recommend you took them regularly for any length of time. They do slightly interact with your medications, and they do have some effects which are not good for your heart. What I would recommend is using medicines that are used topically, like nasal drops and sprays, eye drops, steam inhalations and good old-fashioned decongestion rubs, and these will actually work pretty effectively as decongestants, but they won't interact with any of your medications or be harmful to you. Indigestion remedies. Some of these have a high sodium or salt content which can promote fluid retention and aggravate high blood pressure. So what we'd recommend is that you take a low sodium preparation. There are some available like Malox and Mucogel, but really I would just say to get some advice from your GP if you have any new pains, especially as we know gastric and cardiac pains can be confused, but actually if you have indigestion they can prescribe something regularly for you that will be useful for you. Painkillers. So ibuprofen is available over the counter and is contained in things like Advil, Anadin, Cuprofen and Nurofen. What it can do is promote fluid retention, so that it can worsen heart failure and high blood pressure. It can oppose the action of ACE inhibitors too, but the main thing really is that it enhances the bleeding potential of warfarin and other anticoagulant medications, but also your antiplatelet medicines. So I wouldn't recommend that you took ibuprofen at all unless it was under the guidance of your own doctor. However, you can take medications like paracetamol, that's fine. Also, the codeine-based painkillers like cocodamol and codidromol are okay. Some of the soluble formulations though do have a high salt content, so again I wouldn't take those if you're having them regularly, because they can promote fluid retention and exacerbate high blood pressure, and like I say, that can be a problem if you've got high blood pressure or if you have heart failure. So really I would just say always check with a pharmacist before purchasing these. Herbal remedies. So this is just to say really that there's very limited information on interactions with heart medicines of herbal remedies and suitability for patients with heart disease. There has been some national recommendations, however, about things that we shouldn't recommend specifically. Omega-3 fatty acid capsules used to be recommended for patients who'd had heart attacks and who couldn't manage to have 3 portions of oily fish a week. But since then there have been trials that have shown that actually they're no more beneficial than having olive oil in patients who are already on maximal treatment. So we would say we wouldn't recommend them, but there's no evidence that they will harm you. Again, recommendations suggest that you shouldn't take supplements containing beta-carotene to reduce your cardiovascular risk, because there's no evidence that that works. And similarly, antioxidant supplements, vitamin E or C or folic acid, are not recommended to reduce cardiovascular risk. If you take these for other reasons, if you have low folate, for example, that's absolutely fine, but they don't have any proven benefits in terms of your heart specifically. So I'm just going to end with some general recommendations. So do carry an up-to-date repeat prescription with you. This is really helpful if you do end up in hospital, or even if you're just at an outpatient clinic appointment. It's just very, very useful for us to be able to check what medications you're already on in terms of dosing, and sometimes even brands of different drugs. It's useful to know. Try to use one pharmacy for continuity of care. Your pharmacist should get to know you, they'll know your drug history, they'll know what medications you're normally on, and they'll identify any drug increases or drug interactions, and they'll be able to give you advice if you want to buy anything over the counter. Do ensure a good supply of medications. It seems really obvious, but like I mentioned at the very start, there are some drugs like your antiplatelet medicines where it could be very harmful indeed if you stop taking them suddenly. And do report any suspected adverse effects. The whole point of this is that it makes you feel better, not worse. So anything that you think is not suiting you, please do let somebody know, because there's nearly always something we can do about that. So at this point, I'd normally ask if anybody had any questions, but as I'm not with you directly, if you do have any questions, please ask the cardiac rehab team. They can't ask you directly, they can always feedback through me. So many thanks indeed for listening.